One concept that I wanted to add to what I said about countertransference. You may be familiar with it, but if not, it's very important practically, just to find out from you, who of you is familiar with the concept of concordant and complementary identification in the countertransference? Okay. Who is not familiar with it? Okay. So let me very briefly summarize it. Countertransference can be divided from various viewpoints. One of them is acute and chronic countertransference. Acute countertransference is the useful one that I've been discussing with you, what happens in each session. But some patients gradually change one's attitude toward them. Without realizing, we change our internal attitude with some patients. Either we prefer them over everybody else, we are looking forward to when that particular patient is coming, or to the contrary, we think, oh my God, do I have to see this guy again? So there are long-term chronic countertransference developments. It's important that we are alert to them. If we feel that over a period of time, our internal relationship to a patient makes it different from what is usual, that's an indication for self-analysis by the therapist. It usually indicates some issue in the transference that one is experiencing but not understanding. So it requires analysis of the countertransference outside the sessions with the patient. In the morning while you are jogging or in the shower, a patient may preoccupy you more than anybody else, and you may be unusually either positively or negatively involved. That's a reason for self-analysis, for discussing with colleagues or asking for consultation or supervision. That's one concept. The other is the concept of concordant and complementary identification of the countertransference. I'll give you a simple example. Patient comes in and says, I failed the test. And the therapist feels, oh, that's too bad. He was making such an effort. We were working on this. And so the patient has remained silent, but the therapist has had that sense of really feeling bad about this. And he tells the patient, I think you are silent because you have the feeling it's the end of the world and that you'll never be able to solve that or come out well on this. So there's a kind of a derrotist attitude which complicates your mourning over having failed the test. End of the first example. Second example. Patient comes in and says, I failed the test, and again remains silent. And the therapist feels, I knew it, I knew that was going to happen. He's not studying, not paying attention to what I was saying, now he has it. And the therapist says, I think you're silent because you are afraid that in addition to having failed the test, that now I might be very angry with you for having failed the test and very critical and devaluing. You notice that the patient behaved exactly the same way in both cases. The interpretation was completely different. In the first case, the therapist identified with the patient's central emotional experience. That's concordant identification in the countertransference. In the second, the therapist identified with the critical internalized object of the patient who was attacking the patient. So that in the second, the therapist was enacting an object relation as part of the activated transference. So in concordant identification, we experience empathy with the patient's present emotional experience. it helps us feel with the patient. In complementary identification, we are able to understand better the relationship that is going on in the transference and who is playing what role. That was the concept I wanted to clarify. It's very helpful in practice. And now we come to tactics. Tactics are specific interventions with severe personality disorders that protect the treatment, deal with emergencies. One is contract setting. Contract setting is not a written document, but structuring the treatment to assure the survival and safety of patients, therapists, and treatment. And of course, we early try to eliminate secondary gain of illness. We are very attentive to secondary gain and try to control it. Patients who are not working, we are saying one of the conditions for the treatment, you will have to go back to work or to study a combination. And we give the patient a period of time. We give him 3 months or 6 months, whatever, but we try strongly to eliminate secondary gain when that exists. Then, of course, we decide whether there are particular issues that need to be controlled, and that may become threats to the treatment, and that we structure, as we said, contract. A very important one is suicidal behavior and self-destructive behaviors, a very frequent symptom of severe personality disorders. And management of suicide is therefore a very important overall tactic. To summarize it briefly, patients who are suicidal, who have chronic wishes to kill themselves, who hope that they are going to die, who have made suicidal attempts, we evaluate whether their suicidal threats or behavior is part of severe depression or whether it's an expression of the personality disorder. So you see again the importance of studying initial symptoms very carefully. If suicide is part of a severe depression, you have to treat the depression. That may mean combination of psychopharmacology and psychotherapy, inpatient or outpatient, using all the criteria of suicide as part of the depression. So there, it's the depressive illness, and suicide is a complication of a major affective disorders, that has to be treated. If, on the other hand, suicide is part of a behavioral pattern of the patient, every time the patient has a temper tantrum, he threatens with suicide. Every time the patient family doesn't do what he wants, he becomes suicidal. They tell a patient of mine stays at home, doesn't let the parents go. This is a 21-year-old man who is graduated from secondary education and then has done nothing except going out with friends, and declares himself being very ill, and clinically shows no manifestation of depression, but uses suicidal threats, doesn't let the parents go on vacation. He tells them, you go away, you leave me alone in the home, I'll kill myself. So the parents don't go on vacation. So what we do in these cases is, first of all, telling the family that they shouldn't be controlled by their son's or daughter's suicidal threats. That from now on, suicide is between the patient and the therapist, because the parents being controlled by suicidal threats just reinforces it. And we tell the patient, when he feels seriously suicidal, he has two possibilities. One, to discuss these problems with us in the sessions. We are happy to do that. Or if the patient feels he can't control the behavior, the patient has to go to an emergency psychological or psychiatric service, be examined, if necessary, hospitalized. His commitment has to be either he controls the behavior or he carries himself into an emergency service. And if the patient says, I cannot predict when I feel suicidal, it may come from one moment to the next, we tell them, yes, and from that same moment to the next you decide, will you discuss it with me in the next session, or are you going straight to the hospital? So that the patient has to assume the responsibility. We open the possibility of his getting hospitalized, but at the same time, he takes on the responsibility for his behavior as a condition for the treatment, which we're establishing as we establish the treatment contract. If and when we do this, we immediately have to consider the interpretation of the psychodynamic of this move in the sessions. In other words, we have to interpret what is the function of the suicidal behavior with whatever knowledge we have. The effectiveness of the control is the combination of limit setting and immediate interpretation in the transference of the function. What is it that means that the patient wants to kill himself? What kind of relationship is that he establishes with the therapist? Just to start out with, on the one hand coming to be treated, and at the same time telling the therapist that I don't want to be treated, I'm going to kill myself. So we point out a profound internal conflict around being treated, and so we discuss with the patient whether he really wants to be treated or not, and to what. So we begin to interpret what the meaning of the suicide as well as controlling at the same time. This is a very important and highly effective technical intervention. Transference Focused Psychotherapy has been, in that regard, an excellent way of dealing with characterological suicide. There are two types of this characterological suicide. One, typical patient with borderline personality disorder, which is impulsive from one day to the next on open sky. And there is another form of suicide in which patients carefully prepare over a period of time how they're going to kill themselves, keeping it a secret, and with the secret pleasure that they are going to kill themselves, regardless of what anybody else is trying to do to help them, with a sense of triumph and hidden grandiosity and avoiding conflicts in real life, quite typical of narcissistic personality disorders. So there's a type of narcissistic personality disorder in which chronic suicidal tendencies become an important issue that has to be discussed in the treatment. More about this tomorrow. Yes?
Just one question. What would the response be if the patient says, I can't take that responsibility? I can't guarantee that I can decide whether to go to the hospital or not.
Can you please repeat your question?
Yes, I was just wondering what would the response from you be if the patient says, I can't take that responsibility, I can't take responsibility for deciding whether I go to the emergency or not in regard to the suicidal threats or...
That who can't take the responsibility?
If the patient says, I can't make that choice, I can't take that responsibility.
What does it mean that he can't take, that he doesn't want to? Yeah, if the patient doesn't want to accept our conditions for treatment, we don't treat him. I can't take means I don't want to. So, contract setting is a very serious business because we have had bad experiences with therapists who try to bypass this principle. One of our patients treated by a new and rather inexperienced and some grandiose therapist, let's confess it, the patient says, I'm not commit myself to that. If you wish, treat me. If not, don't treat me. You notice the narcissistic features. And the therapist decided to treat the patient anyhow, and the patient committed suicide 6 weeks later. So it's a very important principle. A related tactic is what we do with behavior that we have to control, that only emerges during the treatment, not at the beginning. For example, there are patients who call frequently by phone, and they call all the time by phone. So we tell the patient, if you have an emergency, I will be glad to talk with you at any point of time. If it's a real emergency. If it's not an emergency, I will tell you this is not an emergency. We'll discuss it the next session. If you call me again for something that you know is not an emergency, I will not take a phone call for a week. If you call me again for something that you know is not an emergency, I won't take a phone call for a month. You do it again, I won't take a phone call for a year. You do it again, I won't take a phone call for your entire treatment. And of course it's very dangerous because one of these days you commit suicide, lie on the highway, car in blood, and I will only find out about it in the newspapers. So we tell the patient very clearly that there are structures and that we are going to reasonably respond always to emergency. Let them know when it's not an emergency and then expect them to keep the relationship strictly in our twice a week 45-minute session, which by the way are always face-to-face. We don't use the couch because you get much more information in face-to-face individual, face-to-face sessions than with patients on the couch if it is not standard psychoanalysis. In standard psychoanalysis, it's helpful to have the couch, but not in psychoanalytic psychotherapy with severe personality disorders. Of course, the same is true for homicidal impulses. Patients who are dangerous have to drop all their weapons. We insist that they get rid of all weapons. And of course, with patients who are potentially violent, we explore how are their superego function, how is the intensity of their aggression, and the combination of severity of the personality pathology, the integrity of the superego or antisocial features gives us an indication whether they are treatable and what are the conditions that we are going to establish. There are patients who are clearly dishonest, and it's important and it's important that as soon as we discover that, we openly discuss that with the patient, that we cannot trust what they are telling us, and that's an important issue that we have to examine, that they present themselves in a way that one cannot believe what they are saying. One has to differentiate. There are patients who come already with a history of antisocial behavior, and then one has to make a differential diagnosis of the severity of the antisocial behavior, which will indicate the prognosis, and that we are going to talk about that tomorrow. It's one of the subjects differential diagnosis of antisocial behavior and its prognostic features. But sometimes we only discover in the course of the treatment that patients are dishonest, and then everything else has to wait until we explore the reasons for which the patient cannot be honest, the effect on ours and all other, and of course all other relationships. Patients who enter the treatment with a history of being dishonest, and we have decided to take them in treatment because the overall prognosis seems tolerable, may require third sources of information. In other words, patients whom we think already during the evaluation that we will need information about them, we establish as a condition our right. This is frequent with adolescents and antisocial behavior, where we ask for authorization not only keep in touch with the family, but also with the school. Sometimes people who have problems with the law, the authority of being in touch with the legal authorities about the patient. Patients with substance abuse and alcoholism. If the patient is addictive, is truly dependent, that needs to be treated simultaneously with transference focused psychotherapy. So specialized treatment of drug abuse and alcoholism becomes essential when there is true addiction. If there is alcohol abuse or substance abuse, but without physical dependency, this can be handled in the psychotherapeutic situation. We make it as a condition for the treatment that the patient stop the use of drugs or alcohol, which patients are able to do if they are not addictive, and that differential diagnosis has to be established. Regarding eating disorders, if there is a bulimic illness, in general, the treatment of bulimia, if weight is maintained within reasonable limit and patients don't have excessive vomiting, can be carried out as part of transference focused psychotherapy. If the patient vomits frequently, 5 to 10 times a day, you have to study the serum amylase metabolites. Then these patients need at the same time being medical treatment because such high frequency of vomiting creates dangers to the patient's physical health. If the patient is simply severely obese, this is a very difficult treatment. General principle is that with morbid obesity, we discuss with the surgeon whether there's an indication for intervention, surgical intervention, and whether what are the conditions for surgical intervention. If the patient has an obesity, but it's not a morbid obesity, he's not 100 pounds or more overweight, then it is preferable to wait advanced stages of the treatment in which one can indicate a dietitian and a realistic diet. This is a difficult long-term treatment, and it is not dangerous as part of the psychotherapeutic relationship. If the patient is anorectic, again, it depends on the degree to which the patient is underweight. If the patient is 15% underweight, the patient should be treated in coordination with a dietitian. If the patient is 30% underweight, probably the patient should be hospitalized and treated with a cognitive behavioral approach to a point where the patient reaches normal weight, and then we make it as a condition for the treatment that the patient maintains the normal weight, and then we may have to have come in once a week and be weighed by a nurse. And of course we analyze the psychological issues involved in all these eating disorders. We expect the patients to come regularly at all sessions and on time. If patients do not, usually that's an expression of acting out of negative transference that needs to be interpreted, analyzed, and made as a condition for continuation of the treatment. I already talked about how to deal with phone calls, and we already talked about secondary gain. One very important complication, I'm hesitant. Before we go into hierarchy, it will end with that. One important complication are severe paranoid regressions. Severe paranoid regressions that consist in the patients losing sense of reality testing in the sessions. I give you an example. I treated a patient, a physician of the same medical complex where I worked, a narcissistic personality, sexual promiscuity. He came in one morning enraged, accusing me of having forbidden all the nurses of the medical complex to have sex with him, and threatening to beat me up, and extremely agitated. The night before that, he had invited a nurse to dinner at his home. In the course of the conversation, she had told him that she knew me, and then later that evening she refused to go to bed with him, went home, and in the course of the night he decided that I must have told her not to go to bed with him, and that escalated. I forbade all the women, all the nurses of the medical complex to go to bed with him. He was delusional. And as I showed my shock, he said, "Don't pretend, don't play innocent." He was ready to beat me. So what I did, and that's the technique that we use. First of all, I put my glasses away, just precaution. And then I told the patient, I believe that you are convinced of what you are telling me. So you don't need to belabor the point. I know you're absolutely convinced. Now, I can tell you what I believe if you let me talk. And the patient says, so. So I said, I think this is complete madness. It has nothing to do with reality. Totally, totally crazy. And I told the patient, and you have to decide whether I'm lying to you or whether I'm really convinced that you're crazy. If you think that I'm lying, let's talk about the fact, why would I be lying to you? What does it mean that your therapist lies to you? If you don't think that I'm lying, then we have to talk about what does it mean that I'm convinced of absolutely opposite of what you are convinced. The patient said, well, it's not that you're lying, but without being aware of it, you just have been rolling your eyes, like indicating, don't get involved with that guy. I told him I thought that was equally crazy. and that I was convinced that what he was saying was mad. And I told him, so we have two completely opposite realities here. And one of us is crazy and the other one is reasonable. We have no witness, we can't decide it. So the only thing we can do is to accept that there is madness in this room that we cannot, that is madness in this room that we cannot locate. And, but it's a madness that has a clear content to it. A powerful man is avoiding that a man who depends on him have any relation with women. It's a form of psychological castration. And the patient got very anxious at this point and had a memory of his father when he was 7 or 8, who was a local physician, an extremely enraged, irascible man, one night because he was so enraged and the dogs were barking, cut the vocal cords of both his dogs. And my patient, who was 7 years old, was frightened to death. So the patient started to have a very important memory at that moment when I pointed out that we lived in incompatible realities, but analyzed the content of what was the crazy thought about which we disagreed. That's the method of incompatible reality, which can be very effective under such conditions. One other complication I still want to mention is the syndrome of arrogance described by Bergen. It consists in patients becoming extremely aggressive in the sessions, being unable to hear any reason, being close totally to any cognition. It's as if they were stupid, with an extreme curiosity about what the therapist is doing and any and all aspects of the therapist's life. Curiosity not about the self, but about the therapist. So aggression, pseudo-stupidity, and curiosity are the characteristics. The problem there is in severely acting out of aggression while trying to avoid consciousness of the pleasure in the enactment of that aggression. And as one interprets the patient's refusal to think out of fear to recognize his own pleasure in the attacks, that opens the symptom. I think I've given you examples of tactics, and of course that is only a sampling, and in the manual, which has now appeared, of Transference Focused Psychotherapy in its 3rd edition, the authored by Yeomans, Clarkin, and myself, you find great detail of tactical utilization. To conclude, we have what we call a hierarchy of therapeutic interventions, meaning urgencies that override everything else and have to be considered in the sessions. Some of this will already be well known to you. First of all, suicide. If there's real acute threat of suicide, you have to structure that, take care of it. Second, threats to treatment continuity for whatever reasons. Obviously, if you don't have a patient, you don't have treatment, so that everything has to wait until you are sure that the treatment can take place. Third, dishonesty in the communication. As I mentioned already, that takes highest priorities if the other two are not involved. Fourth, contract breaches. In other words, the patient breaks his commitment, breaks the contract. We have the method of giving every patient a second chance and tolerating it, continuing the treatment, but during that second chance, interpreting consistently the risk of the end of the treatment if the patient again breaks the contract. So it becomes a sort of Damocles hanging over the treatment. That's a very effective way of controlling acting out. And of course, acting out means all the situation in the patient expresses in pathological behavior rather than in verbal communication what is going on. It may happen in the session that the affectively dominant subject is the way the patient behaves rather than what he says, as well as that the most effectively important thing one day is going on outside the sessions. A very important problem are narcissistic resistances that, of course, we'll explore tomorrow, and of course, acting out occurring in between the sessions, as I already mentioned, sometimes may become affectively important. And finally, there are many sessions in which it is as if nothing happens, and patient talks about pure trivialities, and it seems like a waste of time. That's an alarm signal. We have to ask ourselves, what's going on here? We have as a general principle impatience in every session and great patience in the long run. Impatience doesn't mean that we are tense and nervous in each session, but trying to work and diagnose and resolve whatever seems to be paralyzing the work in the session. And patience in the long run, in the sense that patients repeat in repetitive cycles their learning. It doesn't go straight forward, but in a kind of helicopter, I don't know the exact word, in a helicoidal way in which the same problems are repeated gradually with variation, and so we have to learn to be very patient in the long run. The opposite is dangerous. Some therapists are extremely dangerous, session after session after session after session. And then suddenly they blow up and the treatment comes to an end. So there is a certain risk in being too patient with nothing going on. It's helpful to be alert in each session while being patient in the long run. Thank you for your attention.